Okay.
Anyone joining? We'll get started. All right, welcome everyone. Thank you so much for coming to our presentation. Happy Process Palooza to you all. We'll do a couple introductions first and then we'll get going. For anyone on the Zoom call, there is a chat screen. So if you have any questions, feel free to join the chat. And we'll probably just answer the chat ones at the end. But for anyone here in the room, interrupt us, raise your hand anytime. We have plenty of time for our presentation and questions. So we'd like this to be more interactive versus lecture style, so don't hesitate to do that. If anyone is a Lean Six Sigma yellow, green, or black belt, there is a sharing station down the hall. So if you guys want to share your story, talk about how Lean Six Sigma has benefited you, it would be great to share with everybody. So I think that's all the plugs that I have. We'll go ahead and get started. My name is Stephanie Brooks. I am the Director of Practice Development at UC San Diego Health. And what that means is UC San Diego Health is really working on expanding their ambulatory care footprint across the community. We're so good at the work that we do here at our campuses, at Hillcrest, you know, having the top-notch scientists and researchers and providers here on campus, but we're really looking at what can we do for our community right now and how do we bring that expert care out to where people live and work and play. So my job is really expanding that care, and as we expand, we're trying to expand it the right way, building these lean principles into the way that we provide care, becoming as efficient as possible, and making sure that we deliver the most prime patient experience for everyone that we treat. So my background, I'm a physical therapist by background. I saw all the things that went wrong in my physical therapy practice, so I started working on how to make things better within my PT department. And then I just started to love this type of work. So as I grew within medicine, I took on more different projects and work and went to UC San Diego Extension and got my black belt there. And I'm now applying those principles to how we deliver care in the community, which is really exciting. So I'll let Amy introduce herself and then we'll get started.
My name is Amy Markley. I've been in the healthcare field for about 12 years, with UC San Diego Health for 2 as an LPN. I had the pleasure of going up to Virginia Mason in January to learn their lean process with workflows in primary care. I then transferred into this position as a practice workflow specialist and loving all of it.
And I'm Elaine Huffman. I'm a medical assistant. I have been for 8 years. I've been working with UC San Diego for 6 in out-of-script family medicine practice. And I've been asked to do this work with Amy, and we went to Virginia Mason together and looked at their processes and how we can bring those into our faculty care here at the UC.
What's great about having them is we brought the people that did the actual work to really learn the lean principles, become experts themselves, but then really work in a consultant role within our department so that we have the voice of the people that do the work. We have providers that are engaged with us as well. So we're not just going to Virginia Mason, learning some tools, and then doing a plug and play here. It's really how do we make this work for our providers, patients, and staff at UC San Diego. So the objectives of what we'll talk about today are how to teach a black belt to advance a slide. Right?
Get the chat set up.
Yeah, I think we have to close the chat. It's the problem there. Yeah, because it won't let you advance either way. Right.
Yeah, I'm all here.
Oh, I got it. I got it. Okay, that's clear. So we'll have a project that will improve the process of Zoom at Process Palooza number 3 next year. So as we go through today, we're going to talk about the purpose of flow, what flow means, and just a little bit of background on flow. It's really a way that we bring the lean principles into the clinic, and it's a way of providing standard work for our providers and staff so that every patient gets the same experience by any provider, any staff member at any time. So what we found earlier is that we would have floats that would come into our different clinics and say, okay, I'm working with Dr. Robinson today. What are those preferences? Okay, tomorrow I'm working with Dr. Adamson. How does she like things run? And so it was very confusing for our patients, for our staff, and then the provider. If they're working with someone different that doesn't know their way, it would just ruin the whole day and create a flow buster. So What we'll talk about today are what are those elements so that we can stay in flow. We'll talk about how UC San Diego's commitment to this efficient type of work provides a better lifestyle for both our providers, our staff, and especially our patients. And then we'll talk about how we can use our lean principles in space design, because we're building a lot of new facilities. So how can we build them with the foresight ahead of time to make sure that we're supporting the standard work that we want them to follow in the most efficient process possible? So why are we working on this right now? When I was a provider as a physical therapist, I was getting burnt out just on the documentation that I had to do, keeping up with all the quality metrics, seeing our patients, making sure my cancellation rate wasn't too high. But our providers, as far as primary care and medicine, it's an alarming rate at the burnout that they're experiencing right now. 54% say that they are burnt out currently. 88% say that they are moderately or severely stressed every single day. And this is a sad one that I really hate to report, but 59% of providers right now say they wouldn't recommend their son or daughter going into medicine. So that's really disturbing. You spend all this time and energy and love and passion to treat patients and to help people. And then after a couple years, you're just like, forget it, this is too much. Our providers are working all day. They're seeing 18 to 24 patients a day just in primary care. But then they go home and they log back onto the computer to do more work at home, because they have tasks coming in on Follow My Health or My Chart, and they want to be responsive to the patients. They want to let them know what's going on. But it's just creating just an overwhelming sense of I can never get away from work, even when I'm off or on vacation. So UC San Diego's commitment to this, Amy is going to tell you about.
So we're committed to bring joy into the workplace and reduce that burden of work for the physicians along with the staff by getting today's work completed today. Well, how do we do that? By standardizing all of our processes in our community care and ambulatory care, and getting the providers and staff home for dinner so they can enjoy time with their family, and also getting today's work done today. Elements for success, again, standard work for both providers and staff. Leader standard work to ensure hardwire behaviors and sustainability of improvements. And then we also introduced daily engagement, which is a tiered structure to ensure alignment, improvement, and readiness. Also, we have an infrastructure to escalate any issues and solve problems in real time, and visual management to engage frontline and drive outcomes.
Yeah, so the visual management system, I'm curious, does anyone go to Orange Theory? Nobody? You know what I mean? Okay, so I'm an Orange Theory fanatic. I'm obsessed with this place. And what I love about Orange Theory Fitness is that you wear a heart rate monitor on your wrist or around a chest strap, and you can see on this screen, and you can see everybody else too, exactly where your heart rate is. And the reason it's called Orange Theory is as you get 12 minutes or more in the orange zone, you burn calories for up to 36 hours after that workout, versus running, go for a run, you'll burn calories for an extra 2 or 3 hours. If you lift weights, it's going to be almost 24 hours. But if you get 12 minutes in the orange zone in Orange Theory in this high intensity interval training workout, you're golden for 36 hours. So it's really the best type of workout that can challenge your body. So as a PT, I'm obsessed with it. I love it. But what I really love about it is I know exactly where I am. If my heart rate's at 82%, my bar's green. And if I'm like, okay, I'm on the treadmill, if I just go a little bit faster, increase that incline, I'll get a point in the orange zone. And so for me, working hard and seeing those results real time is extremely helpful. If I were just at 24-hour fitness, running on a treadmill, I'm like, oh, I feel tired, I'm good, I'm just gonna keep it at this rate, right? But that visualization shows me where am I at right now, where's my goal, and how do I get there? I know right away where I am in real time. So we've introduced a visual management system for our staff and our providers. This is what our boards look like, but they're actual big whiteboards hung on the side of the wall in our clinic. So we talk about on the side, everyone has their own Bitmoji. So we know who's in and who's out today and who's covering for who. Down at the bottom, we talk about our readiness. So do we have the right staffing today? Do we have any problems with technology? Is there an equipment issue? Like the EKG is down, we need to borrow one from somewhere else or place an order. We talk about our processes. Is everything green there? Are we having call center issues? Like patients are calling to schedule, but they're getting booked into the wrong appointment. That could be something we'd be read and processed for. And then supplies. Do we have all the supplies we need to safely and on time treat patients today? We talk about our readiness. But also, my favorite part of the board is the visual management and alignment section. So at the very top of the board, we see the UC goal for the whole healthcare system. Then we have a department goal that's initially tied right to that. So what do we do here in our department that drives an outcome for the entire system? Because the more the work that we do here in our department to drive outcomes for the system, the better off we will be and our patients will be. So now that we know our department goal, we have a graph that will say our current performance. So if our Press-Ganey scores are at the top decile, we'll know we're in the 75th right now. Our goal is to be at the 90th percentile, so we have a gap we have to close. Once we've identified we have a gap or improvement, we go through the 5 whys and identify a root cause, and then we put in a plan for countermeasures or experiment tracking. So what I love about this visual board is that the staff now aren't just there to chug away and see patients all day. They're actively engaged in driving outcomes to be the best they can in their own clinic or their own department, but then they also see how the work they do right here affects the entire system. So I love that they can see it, the feedback we've had from the staff and the physicians. So like, well, why are we red there? We got to make it green. So really just instead of keeping their head above water and treating patients all day, they're actively engaged in our improvement efforts and want to be a part of it, which is phenomenal.
Some key components of flow are that we have huddles every day, and this goes from the clinic aspect, having the whole clinic be engaged, but also having the dyad or the physician and the flow manager or the nurse and the MA have that huddle one-on-one so they can really get to know their patients and their needs for that day. We have standard work for patient moving process, agenda setting with the patient, how you get through the appointment with them, form handoffs between the provider and the flow manager or the nurse and MA, and then how to do an after-visit summary of the patient and actually explain the information that they got in today's visit. And then we have today's work done today where we close patient encounters, do 3 games of sand, have a warm handoff between the staff, and we repeat that with every patient at the time.
Sorry, could you explain what 3 grains of sand is?
Yes, I'm going to explain it in one of the problem slides. So huddles, just to go a little deeper, is they occur each morning at a standard time, and all providers and staff are expected to attend. A diet huddle, they review the schedule, identify any patient care gaps, pen orders, and they determine where rings of defense will be needed. Rings of defense is an outside resource that they can draw upon to help them with that day's flow, to make sure that they actually stay on time and meet all the patient's needs. And then clinic huddle, anything that the dyad huddle needs to be escalated, they would do that at that time. And then we see where we can see our patients today safely and on time and make sure that we're ready for the day. The standard work element for the patient rooming sequence allows us to capture care gaps, prime measures, and vitals in a timely manner. So we have a set time to do a patient rooming sequence, and we make sure that we get all of the things that we need in that time because we have a standard to do it. For agenda setting, we have the staff member and they allow the patient to bring 3 most important issues to the provider and discuss it so that the patient can have focused time with the provider. And then the staff is asking the patient 2 to 3 times so that the provider doesn't miss any concerning issues if they weren't brought up at the very beginning.
It also helps us stay on time because some patients will save up all of their issues for one visit, and it's a 20-minute visit, right? So let's see, like, what are the top 3 things that you need to identify today? And then the medical assistant, our LVN, can set the stage and say, all right, you know, I know you have 10 things, and to do those justice, we really will have to schedule a follow-up. So what are the top 3 things we can talk with you today about? And then the provider's not spending that valuable time with the patient re-explaining that. They already know what their top 3 things are, and they're going to get them scheduled to come back for the others.
And then warm handoff eliminates waste and provides the staff to give real-time updates to each other, including why the patient's here and the results of the agenda setting and what care gaps need to be closed by today's visit. And then for the after-visit summary, we are reviewing the important elements and information of the visit and scheduling that follow-up appointment in the room so that we're actually closing the loop with with each patient to provide a great experience.
Yeah, and the after-visit summary is so important because we're trying to make defects not come back to us. And what I mean by that is every time we don't close a visit and answer all the patient's questions, what are they going to do? They're going to leave the room, and then they're going to go home, and then what? They're going to call us. And what happens when they call us? They go to the call center. The call center tries to call us and says, oh, we need to reach Dr. whoever's medical assistant. Like, well, they're with a patient right now. They'll call you back. So that creates this chain of events where they're getting tests and phone calls that if we close the visit right and we had a printed account and there's all the details you need to know, the best way to call me is through my chart. then a patient knows, you know, here's the best way. My question's already answered. I probably don't have to call back, and I feel good about the information I have leaving. So this after visit summary is all about preventing what we would call a defect when a patient just needs to know an answer to something. We see that as we didn't answer their questions while we had them in front of us.
Here's an example of our standard work for the established patient learning sequence. And you can see that we have a high-level step to complete, but then how to complete each step, and then the why behind that step. So for the staff members in the clinic doing the work, that column is super important, because if you don't have a great why behind why you're doing that step, they don't want to do that step, and that's valid, because then we kind of look at our process and see, can we eliminate that step and make it eliminate the waste. And to do today's work today, closing the patient encounter allows other departments to access a completed care note to provide high-level care coordination. And this also helps the provider and staff go home on time, reducing burnout because they don't have to work from home. The 3 grains of sand are 3 pieces of indirect care, which is a refill request, a MyChart message, a telephone call, anything that's not related to the patient being directly in front of you. And these are completed in between patient visits to eliminate batching work at the end of the day. And then we do all of this repeatedly, every patient, every time, so that we can go home for dinner on time.
Yeah. And the grains of sand, the reason we picked 3 between each patient is that we found statistically across the nation, we found that by every 1 patient you see, you're getting about 3 messages from the outside coming in at you. So if we can keep up with 3 throughout the day between every patient, at the end of the day, we might have 5 or 10 indirect tasks to do versus 70 or 80. And then closing the patient encounter, if we waited till lunch, just like, okay, I'll close all my morning patients at lunch. You're working through your entire lunch and you might not get them done. Plus you're not remembering like, okay, what did I do for that patient? You know, going back and trying to document. So we created a workflow in which they document real time in the room. They come straight out of the room when they're done with the patient, they close the chart. They get 3 tasks from their medical assistant to keep up that the medical assistant has already said, okay, these are 3 things we can knock out right now. And then they receive the warm handoff from the medical assistant to go see the next patient. So a lot of elimination of waste, but also keeping up with today's work right now. So at the end of the day, you're done and you get to go home and you're not opening Epic at 7 o'clock at night while your kids are playing.
Yes.
Okay, so designing space to support flow. When we go into a new clinic or an existing clinic, most of the time an existing clinic and say, oh, we're going to bring you flow. But we have a medical assistant or a nurse's station in a central location, and then all the providers are sitting in their offices doing work. So the medical assistant, they room the patient, they write things on a clipboard, they throw the chart down while the patient or the provider's in with the previous patient. The doctor comes back out, they look at the clipboard, they're like, oh, okay, I have a lot of questions, so I'm gonna go see the patient because I can't find my medical assistant. They go into the room, and then the patient just repeats everything they just told the medical assistant that roomed them, right? So the patient's frustrated, and this takes another 10 minutes of a visit time when they're already running 45 minutes behind, right? So that's not an efficient way to run and find each other. So we had to work on how do we design a space that will support the work that we put in place. So I'll let Amy talk more about the co-location and how that supports.
So this is how we support it by co-location, where the provider and either the medical assistant or the nurse sit side by side. It's shoulder to shoulder work to consider most efficient to communicate patient's need and complete any incoming task. It eliminates that, where's my medical assistant, where do I need to go, what do I need to do? It eliminates any need to send a necessary task or emails, because a lot of times before, when I would send a message to my doctor, I'd have to wait because I couldn't find her, and then she'd send it back to me, and it's like I had questions. There's just a lot of back and forth. It ensures that patients' needs are met timely, and today's work is being done today. All of our physicians love this a lot. They never want to go back from this.
Yeah, I would say one of the biggest fears that we've had with our providers is, I don't want to lose my office. Don't take away my office. You guys are evil and you're taking away my office. Why are you doing this? And so we'll talk to them and just be like, you know, here is an efficient way to do things. And would you rather have your office, which you'll still get to keep. You can go back to your office anytime you want. But would you rather have your office that you're going back to all day, or would you rather go home and not have to open up Epic and not have 70 tasks waiting for you when you wake up in the morning? So when we try this, we work through a 30, 60, 90-day PDCA cycle to get their feedback, to improve our standard. But when we've gone back to these clinics 6 months or a year later, we're like, oh, how much time do you spend in your office? Like, take my office. I don't have anything to do with it because it's so efficient for me to be out here. I don't need it. I need a shared space sometimes to make a private phone call, or with the residents, they do teaching or learning activities with them. But most of the time, you give it 6 months to a year, and they're like, I don't care about my office. Get rid of it. Make more patient rooms. So we do have a lot of faculty care existing offices that we're going and introducing flow to. But like I told you earlier, part of my job is expanding our ambulatory care footprint across the San Diego County. So we just opened a new site in Rancho Bernardo. We have one in Encinitas coming up in April. We have one in Eastlake down in Chula Vista this summer. And then we'll have Pacific Highlands Ranch that's in Carmel Valley in the fall. So within a year, 4 really nice new sites that are going up. So we have to think ahead and say, how are we going to build this for the clinic of the future, not how we did things in the past. What we have here is, this is an integrated team of our providers. We have staff, we have the operations directors, we have our architect. We're all working together to say, how does this fit the staff, the providers, but most importantly, deliver the most important patient experience that we can provide. So everyone working together, but using those lean principles is so important. So who's familiar with the 8 deadly wastes in this room? People know about the wastes? So I'll tell you a few of them. The wastes that we see are motion. If you're walking to find something, confusion, you don't know where things are. Inventory, there's just way too much or way too little to support the needs of the day. So we're looking at those 8 deadly wastes and say, how do we eliminate waste in the form of motion or transportation, confusion, and design a space that supports a lean workflow, but also delivers that high patient experience. We can go to the next one. So this is an example of a floor plan that we have for Pacific Highlands Ranch that's going in, if you know where Trader Joe's and Fleet Feet, that little area is off of the 56 in Carmel Valley. So this space, in the yellow, you can see that is patient space, and the green or teal color is, we call it off stage. So that's where the work happens. We have dyad stations here, so the people that do the work, they sit next to each other, they're co-located, and they don't have to walk very far. They stay in their workspace and they go directly to a room. The rooms have 2 doors on them. So one door is from the work side where the provider enters, but the other door out here is where the patient would enter. So they're not having to go through workspace. Providers aren't being interrupted by people walking through. They get the work done and then they go see their next patient. So with this special design, we've eliminated a lot of the motion and transportation. There's not confusion because their workspace is next to the rooms that they'll see patients in. And the patients have a really streamlined workflow to get to the lab, to the restroom, or back up to their car and on for their day.
For measuring success in our current state, we have to manually enter our data into that we have collected through Epic, and we input it into Excel, and then we report it out to the various providers in Flow. This is one of our early providers, and you can see in almost every category after Flow, their measures have improved. I'll give you an example. For her office visit closures, for same day was at 27%. She was only closing about 27% of her charts the same day. After Flow, she was closing almost 80% of her charts the same day. And you can see that her work after clinic hours before Flow were almost 67 hours a month over, and now it's down to 27 hours a month. So still a lot, but we've severely decreased the amount of work that she's doing after clinic.
Elaine, those are impressive results. I'm just curious, the only measure that didn't improve is telephone calls addressed. Any insight into that?
Yeah, so I can speak to that one. So because we've eliminated waste and we're doing better with the after visit summary, we don't have the need to address as many calls. So that's actually a good one to go down.
Okay.
We don't want to see them addressing more calls. We're trying to eliminate those defects of coming in. So we want the calls to actually go down, not up. So that's something we could note on that slide to make it like, hey,
so you see the my chart.
yeah, so they're closing a lot more tasks than they were before, more quickly, but then also not having to return as many calls.
And with our measuring success in our future state, we're going to be using a Tableau dashboard to collect and run the data in real time, where anybody can collect or anybody can access the data. So the providers, the staff, and the clinic managers can report on this data every morning to see actually where they are in real time instead of having to rely on somebody else to report that out. So this will include chart closure within 2 hours of the patient encounter, the task left in the in-basket after the last patient of the day, and off-hours work completed.
Yeah, what's so nice about this one is our current measure, it's a generic report you can pull out of Epic of the charts closed within 24 hours. But our challenge is, well, that's not telling us if we're in flow. You could still be batching them to the end of the day and working from 7 to 10 p.m. closing your charts, and your percentage would be pretty high, right? So we're looking within 2 hours that some they might want to keep open because they're going to wait for a radiology report or a lab result. So they'll keep that open. But 80% of the time, we want our chart closure to be within 2 hours of that patient encounter so that we ensure they're staying on task. When we have this built into Tableau and it's real-time reporting, our leaders, part of their leader standard work is to go out and coach and to observe and to ensure that we're sticking to our standards. Not to say, this is punitive, everyone needs to meet these measures, but to say, how can we help you and how can we better support you in staying in flow? So we look at those and we'll say, okay, well, here's someone that we can really coach because they used to close their charts right away. They were at 60%. Now they're back down to 20%. So how do we go help them and close that gap? So our leaders, we have a clinic medical director and a practice manager. So they're the dyad of leadership there that will work with our providers and staff to ensure that they understand the work. And if they're really just not getting it or need extra support, Elaine or Amy will go and observe and spend time with them and give them tips and tricks to help too. But those measures are so important because in the beginning, we feel like, oh my God, this is so hard. We're running behind. So we teach them we have to go slow and take a step back before we're going to get fast again. It's learning a new muscle memory, learning a new process. And so they feel like they're stressed during the day and they have all this hard work to do. But then when we show them, look at how your after hours work has gone down by 30 hours this month. What could you do with all those 30 hours, right? You could go to Orange Theory and look at visual systems. There's so much you can do with 30 hours a month extra, right? So then they feel a lot better. This is worth it. This time is worth it. I will get more coaching. I will stick with my standard because I can see what an impact it's making in my life. So I wouldn't downplay how important the measures of success are and sharing them frequently so that they can stay on task.
Sustainability. We have that leader standard work, which ensures that behaviors are hardwired. The flow meter for each dyad, the one-on-one training and coaching that Stephanie was saying. And then we're also supported through DES and the flow guidance team. So we have a flow steering committee that meets once a month that we go over how they're doing in the clinics. Does anybody have an improvement ideas? Do we need to implement that and try it out for 30 days? That's going really well right now.
Yeah, and I think there's a DES right after this presentation. If you want to learn more about that system, they have an entire talk just about the daily engagement system. I think it's at 11.
And then we have a video.
My name is Dr. Leslie Wilkinson. I've worked for UCSD since 2004, and prior to that, I worked at UCLA as an attending physician in family medicine. And I really have found flow incredibly helpful. And it's been a little difficult for me to figure out why I like it so much. So I've reflected on this, and this is what I think. So prior to flow, I felt like my inbox work was really overwhelming and depressing. It was just so much, and it comes, and it's very hard to keep up in your regular life. So I was hopeful that going to flow might be helpful, but I was hardly confident. So I feel as though flow has made an enormous difference to keeping my inbox much clearer. And what I really notice is when my nurse isn't available, right, I end up working with one of the MAs that's not in flow, and I'm reminded how different it really is and how much I like this better. So why is that? Well, clearly working next to your nurse is helpful. But that's hard. The people say, well, how much difference does that make? I don't think it's working actually next to your nurse. I think that's helpful, but I think it's the mindset that you're working together. And
Did you guys hear that? One of the things, or what did you guys notice about that video that was nice to hear? What did you guys like? Nothing?
They seemed very in sync together. They were talking about it, they had the same attitude, the same tone, and they were very, like flowing together.
Yep. Yeah.
It seemed like they have less work now, or they do less but accomplish more
Right.
in their day.
Exactly. And I think that because they're next to each other, they're not generating all these tasks back and forth to each other. And the one thing that I really liked that I heard her say was that she feels more empowered. You know, before she's like, oh, should I text Dr. Wilkinson? Should I ask this question? Now with the standard work that we've put in place, everyone feels empowered to work at the top of their license and feel supported by their leadership and know like, oh, well, this is how we do things now. And the providers can ensure that they're supporting their staff and their assistants, but also keeping up with the work as we go, because it sounded like here, like you mentioned in that video, that today, you know, they're doing a lot of work, but they're getting it done as it's coming in versus, wow, we have so much left to do today after the last patient leaves. Anything else? Any other reflections on the video? No. We have another, that's it. We can advance to the question. Questions, make it official.
Are you able to share the slides?
Yeah, actually, I think on the Process Palooza site, they'll all be up at the end of the day.
Okay.
But if they're not, I think the next slide might have our contact information. I can at least tell you mine. If you guys want to reach out to me at any time, it's srbrooks@ucsd.edu. We're happy to help and answer questions.
Is this something that you can share to the specific department? Like if we invite you over to talk to our providers and
Yeah, where do you work at now?
student health?
Yeah, so the way that student health is probably like primary care, urgent care, right?
Yes.
Some more like that.
Ambulatory.
Yeah, so really the principles will remain the same no matter what department. So we would be happy to share the tools and the standards that we have. We have a documented training plan that we can show, you know, how do you roll this out in a new clinic? And part of rolling this out that is difficult is the assessment of readiness, right? We have to remove a bunch of waste first before we can come in and say, oh, now you're gonna all be on flow. Because if they have all these redundant tasks coming in from the contact center or through my chart messaging, it's like we gotta clean up the space first, and now we can apply these principles. Because if we go in and just try to overlay this on a broken system, you'll find less success with that. But yeah, we're happy to share our materials and even come out and do an observation with you.
So how do you, if we're looking to redesign, like, or design a new facility, do we reach out to you as well?
Yeah, absolutely. We can share some of the principles on the on-stage, off-stage floor plans that we've looked at. We are using architects that UCSD has used in the past with other projects, but they've also worked on projects at Stanford and Palo Alto that are very in tune with the lean space design. So we'd be happy to share that with you.
We'll be in touch.
Yeah. It's SR Brooks at UCSD.
Thank you.
What were your kind of your challenges, barriers to implementation, and like over what time frame did this? Because this is amazing. I think change management, culture changes.
Yeah.
So I love it. What did you overcome?
I'll let you guys speak to that.
The culture change was the hardest because people are very set in their ways. So we had to overcome that quite a bit. But we've done this. We have 6 clinics now. We've done in a year. And then we have a lot more to come. We're even going to expand to Ahmed and urgent care. How did you get buy-in from?
So I think it was a lot of PDCA. Like we looked back at our process, how we rolled it out. When we first started, we rolled it out in 6 weeks, and that was way too soon for the clinics to go through all of the implementations, like Stephanie said, to fix the broken processes first and then bring in flow. So we've now, after doing PDCA for almost 3 cycles now, we've come up with a plan that we rolled out with the RB clinic, and it's super successful. It's sustaining, and it's taken almost 8 to 12 weeks, depending on how much time you need for training and observation. So.
And each site has a physician champion and a manager champion and a nurse champion. So they're the ones that are kind of pushing this for the change and helping.
Yeah, because creating that buy-in is the most important part from the beginning. They see it as like, this is another thing UCSD is making us do, right? Oh, or this will, if we ignore it or resist it enough, it'll go away, and then they'll be on to the next thing, right? So we show results, you know, we give some data because physicians love to review the data. And so do the staff too. They're like, wow, you reduced our task by 40% coming in. That's incredible. Like, we want that. So now that we've proven some successful, we call them model line clinics. So it's like, let's create a really successful model, show the data that we've gotten better. And then we have some show and tells. So anyone, the clinic medical director and practice manager for sure, they take a field trip to Rancho Bernardo and spend half a day there. They see patients, they're shadows, they're observers, they get to see. But then anyone that wants to see any provider, say, let's go to Rancho Bernardo, we'll block out half your day, and you guys see for yourself, and you can ask questions. You can ask peer-to-peer, so what's this really like? So I think a combination of the data, I wouldn't emphasize enough the provider champion in that space, because we'll implement it, but we go away. You know, we're on to the next site. So how do they own it? And we have to set them up that the clinic medical director and the practice manager, this is your process. This is your flow. Here's the tools that you need. We'll come back and help when you raise the flag, but we really want them to own it from the beginning and see why it's so valuable. So I think the best is showing them how that they're improving as we move on, but get them bought in the beginning. It's not easy, and some people will never buy in, and some, like, you know, there's the cavemen. It's, what is it, coworkers against virtually everything. So we've got the cavemen out there. They're like, well, they're never going to change, so we're just going to do our best with the 99% that we have, and we'll just wait for them to go away. You know, but so you might not get a win with everybody, but when you create a standard and you have leadership support like we do at UC San Diego Health, you'll be successful.
Just along the same line, I'm sorry, go ahead.
No, please.
Along the same line, Stephanie, so the caveman approach where, and Rancho Bernardo, my understanding was a lot of providers were newly hired into UCSD. So what kind of obstacles or challenges do you anticipate as you and the team go into support established?
Yeah, the seasons clinic. Yeah, so the new providers at Rancho Bernardo, 90% of them were brand new out of residency, and they know that this approach, this isn't something that UC San Diego made up. You know, Cleveland Clinic, Mayo, Seattle Children's, Stanford, this is the way people are practicing medicine because burnout was so rampant. So a lot of the residents and the new people coming in, they're like, oh, of course we do it this way. Like, yeah, duh. But then the other faculty care providers, they're like, I'm already efficient, and you know, I don't want to close my chart because I like to be more thorough. What we have to do is work through our clinic medical directors or our chief of staff, and we have them have those difficult conversations, because the provider doesn't care what I or Amy or Elaine says, how much this is going to make their life better, right? They want to hear it from their peer, they want to see the data, and they want to see it work somewhere else first. So we're pretty specific on rolling this out to clinics. We do a readiness assessment. And if they don't meet certain criteria, that they don't have leadership engagement, their clinic medical director is really not wanting this to come, we're going to put you at the end of the pile. We're going to take the ones that are pulling for us first because they've seen the great results. And just, you know, we're going to make it so successful that you're going to have no choice at the end but to join on. And you're going to want to by that point. So I think you have to be, for your change management, like you mentioned before, your change management strategy is really important of who do we pick, the ones that are influencers, that have good respect from their peers, show results, and then go back, because we don't want to spin our wheels and waste time on a clinic that's like, please don't enter, you know. So we do our best, and we work with the leadership team to determine how we pick those sites.
You mentioned there's like a cleanup process first. How do we learn more about that? Like, where do you start?
Yeah, do you guys want to speak to that, or do you want me to? I don't want to be the so you can reach out to us first, but some of the things we identify, and every department's different. You could do this in revenue cycle, you could do this in finance, anywhere. But looking at a 5S system, are you guys familiar with 5S? It's sort, shine. So it's putting in a standard way where you can always find something. If everything's labeled, it's visual. When something's running low, there's a visual key to order more. So you're not creating all this inventory. But we start with 5S because it's a simple concept to grasp once you roll out a 5S system. So they learn the lean principles, they learn about removing waste, you get the buy-in and engagement of the team, and you create a standard that people they get and they see the value right away. Then you look at and engage the staff of, if you could wave a magic wand, where would you take away waste? What's a redundant process for you? You map a current state. So like, let's map how a patient walks to this clinic today, or how a request goes all the way through revenue cycle to where it produces a report, something like that. And then you look at ways to remove waste. And so once you remove all that waste as much as you can, now we're going to create a standard. And a lot of the places that we visit, you can't improve until there is a standard to improve upon. So some of it was, let's just write a standard, see how that works for 30 days, and then we'll improve upon that. So our transformational healthcare team can share much more information about like the lean principles. You could probably speak more to this than me, but what do you think?
Yeah,
How to get started?
Yeah, I think you described it perfectly, and it really depends on the department, but there are some simple, quick, easy to understand, accessible things. You can do it right away with sticky notes and pens. You don't need equipment. You don't need a PowerPoint. You can just jump in and do. And I think once people see that it's simple and accessible, they're in. And if you do nothing else and you only do that, you've already won, right? There's already progress.
Absolutely.
So a lot of our 5SE in our clinics, every room is standard, so you can go into any room and work out of any room at any time. We do standard procedure kits. What else do we do? A lot of the standard stuff that we can learn in some ways.
Yeah, so we have an injection tray, we have an ear lavage tray, so you're not searching for all the equipment, you just grab your tray and you do the procedure. But doing a current state assessment, Lean Six Sigma tools as far as getting a yellow belt or green belt training would tremendously help, because now that you know how to map a current state, or to understand how to identify waste, you'll see waste in everything. You know, so I have 5S in my garage. It's pathetic.
In my kitchen, my kitchen, my closet.
It is. I have a visual management system at home, and it's gross. Yeah.
So just going off that, I'm with the International Students and Programs Office on campus, and so the population that we work with is not in the medical field, but the population we work with is also very high stress, very high population on campus. Something we've run into a lot is the issue of privacy when it comes to advising whether checking students at the front desk or actual when they meet with advisors, which is similar with the medical field. So do you feel like we would be able to reach out if necessary, do a similar assessment approach to our office, or are you strictly in the medical field?
No, so these principles that the medical field, we're late to the game here. This has been happening in aeronautics. It's been happening in manufacturing is really where it started. Toyota and Ford were really the people that took this off and really was like, wow, this made such an impact. So we learned from manufacturing and the automotive industry, airlines now. So these principles apply to any industry. That's why like getting your Lean Six Sigma, green belt or black belt, it's like, wow, I get sick of healthcare, I can go anywhere I want. You know, your LinkedIn will start blowing up because you can do these same activities to improve any process, no matter where you work. So we're happy to share the tools. Our transformational healthcare team would probably be the most appropriate people, would you say, to reach out to? Because we are really just working in practice transformation within the clinics. But they're the ones that really have the tools and the lean training that would be the biggest help. So I think you guys have 2 more talks today, one on daily engagement and then others on lean methodology throughout the day too. So I would check them out. Yeah. I think we're at time, but we could probably do one more question.
Can you talk a little bit more about the Tableau dashboard and what challenges you have with the data collection and visualization?
Yeah, so I would say our big is just getting things built, because it's such a robust interactive tool that pulls directly from Epic or whatever data source you need data from. And it's just this beautiful thing where you can dig deep, you can click on any department, anytime, any month, you can change your date range. So the biggest challenge is getting the report that you want built and prioritized at the level where they're going to drop everything and build that report for you. So our request has been in a data prioritization meeting. So my job is out there like working with those chief executives, trying to get them to pick my project. You know, like, this is why this is so important. It's going to change healthcare. And look at all the investment we have in ambulatory care expansion. That's why we need data. So it's really, for me, is lobbying our senior executives to make sure that that's a priority and helping them understand viable health. But we have the dashboard for patient-arrived visits, for cancellations, for bumped patients. We have an amazing dashboard that I can go in and pull, like, are we on track with budget this month? And it's right there, and it's real time. So it's an amazing tool. Other organizations use Tableau, but you really customize it and build it to what your specifications are. But it's a great tool. Yeah. Did that answer your question?
Yeah.
Okay. I think we're at time, but if you guys ever have questions, please don't hesitate to reach out to us, to me, and we'll make sure we can provide tools and help wherever you need. But thank you for your time.
Thank you. Thank you.
And I get to thank you.
Thank you very much.
I was going to get to do this.
Thank you.
Stephanie, do you have plans on expanding beyond Rancho Bernardo ambulatory care?
Yeah, so we have about 20 additional sites through fiscal year 20. Yeah, so we'll have 4 before the end of fiscal year 19.